Professor Zhang, and she is from the first medical center of the Chinese PLA General Hospital, Beijing, one of the most beautiful cities in the world. Safety of CF6, microbubble administration, data from a huge number of examinations, 463,434. And this is a paper that was just published, as you can see here, in European Radiology. It is a really great pleasure to introduce to all of you, Professor Zhang. Please give us the updated knowledge on side effects, safety, on our use of contrast media. Please.
Thank you very much. Thank you for your introduction. And I think my topic will answer the last question. My topic is safety findings after intravenous administration of Sonovil to 463,000 examinations at 24 centers. I'm Zhang from Department of Ultrasound, the first medical center, General Hospital of Chinese PLA. It's my great honor to report this article. This article published in the Journal of European Radiology, and the corresponding authors of this article are Yanli Guo from Department of Ultrasound, Southwest Hospital, and Wen He from Beijing Tiantan Hospital. It comes from a multi-center, large sample retrospective clinical study conducted under the leadership of the CUDA, Chinese Ultrasound Doctor Association. It shares a valuable experience from hospitals in 24 different regions of China. I hope the experience of Chinese sonographers in the diagnosis and treatment of adverse events of the contrast agent may provide an important contribution for the safe application of CEUS worldwide. These are the 24 hospitals of this study. They are located in many places in China. And we can see the top hospital, it has over 80,000 cases of CEUS. So you can see in China, we perform many cases of CEUS. And first, the background. CEUS is an imaging method that involves the echo of human blood poured by intravenous injection of ultrasound contrast agents to improve the SN ratio and to observe the microvascular perfusion of tissue and the lesion dynamically in real time. So CEUS is clinically applied to multiple organs and systems, including the abdomen, superficial organs, peripheral blood vessels, gynecology, and other systems. At present, the longest and the most widely used ultrasound contrast agent in China is Sonovil. The average elimination half time is 12 minutes, which in 2 minutes after injection, 80% of the gas is excreted through breathing, and 15 minutes after injection, almost all gas has been excreted. So it is very safe. However, regarding the safety of Sonovil, the existing literature reports are mainly based on the adverse events in the European population, because we know that Sonovil is originally from Europe. And in China, only it has the single center studies. So no large sample and multi-center studies have been reported in China. So in our study, we aim to more accurately and comprehensively evaluate the safety of Sonovil in clinical application of China. Methods. It is a retrospective study from the 2006 to 2019, about over 463,000 cases from the 24 hospitals were enrolled in our study. And we record the clinical manifestations, the number and extent of the AE, the management procedures of all the patients. First, we have to introduce the ACR contrast agent handbook. In this handbook, it introduces the subtype of AE. It can be classified into serious and non-serious AE. For the serious AE, it included the life-threatening and death. For the non-serious AE, it included the mild, moderate, and severe. And it also classified into the allergic-like AE and physiologic AE. It is important to avoid contaminating these two different kind of symptom because the management of patients experience these types is very different. For example, patient who experience allergic-like reaction may require future pre-medication, while the patient who experience physiological reaction would not. It is believed that some allergic-like contrast reaction may involve the activation, the deactivation, or inhibition of a variety of vasoactive substances or mediators, such as the histamine, complement, and kinin system. Contrast agents may cause the histamine release from the basophils and mast cells, but for physiological reactions likely related to the specific molecular attributes that lead to the direct chemotoxicity. And the physiological reaction are frequently dose and concentration dependent. Vasovagal reaction is one of the common physiological reaction and can characterized by the hypotension with bradycardia. Here comes the results for the rate of AE. Overall, we have 157 AE were reported, yielding the frequency of 0.034%. No deaths were reported. And the most patients are mild and moderate AE. And we can see here there are 4 life-threatening cases, and I will introduce you later. The mean age of patients with AE was 47.5 years. The number was normally distributed, centered on patients aged around 50 to 60 years. There was no significant gender difference between the patients with and without AE, and for the patients in different intensity of the non-serious AE. For the organs, the highest frequency of AE was noted for vascular CEUS. So we should pay more attention to the vascular CEUS, and followed by the super organs other than breast. Here, the super organs other than breast, and then the gynecological CEUS in the liver. For the liver and kidney function, of all the AE patients, 60% abdominal CEUS had varying degrees of abdominal liver function, and 20% of gynecology CEUS patients had varying degrees of abnormal renal function. There was no significant relationship between different doses of contrast agent. And the incidence of AE with the highest rates of 0.076% occurring in 1 milliliter. And then I will introduce some symptoms of the different kind of AE. We can still remember that the AE can be classified to serious and non-serious. For serious, we have the life-threatening or death. And right now, I will introduce the non-serious, which can be classified into mild, moderate, and severe. First, let me introduce the mild AE. For the allergic-like symptom, we have the limited urticaria and nephritis, the limited itchy, scratchy throat, cutaneous edema. For the physiological symptom, we have the vasovagal reaction that resolves spontaneously, constant flushing, warmth, chills, limited nausea, vomiting, headache, dizziness, anxiety, and altered taste. So they are all mild AE. For moderate AE, we can see the physiologic symptom has the larger part than the allergic-like symptom. For the allergic-like, it include the diffuse urticaria practice, diffuse arrhythmia, with stable vital signs, throat tightness or hoarseness without dyspnea, facial edema without dyspnea, and bronchial spasm, mild or no hypoxia. For the physiological symptoms, we have the vasovagal reaction that requires and is responsible to treatment, and the protracted nausea, vomiting. And for severe AE, the allergic lag has larger percentage than the physiological symptom. For the allergic lag symptom, we have the anaphylactic shock with the hypotension and combined with the tachycardia, the wheezing bronchial spasm with significant hypoxia. And for the physiologic phenomenon, we have the vasovagal reaction resistant to treatment and arrhythmia. So they are the severe AE. And for serious AE, as I have reported, we have no deaths, but we do have 4 patients that is life-threatening serious AE. So I will introduce the 4 cases. First case, this patient have the AE at 5 hours after the carotid CUS. So remember, the vascular CUS may be dangerous. So pay attention to the carotid CUS. The patient felt pain in the lower abdomen from the bilateral inguinal region to the subambulatory region. So the day after CUS, 4 dark yellow stools appeared. On the 3rd day, there were 2 to 3 episodes of lower abdomen pain. So something may happen in the patient's abdomen. On the 4th day, the ultrasound showed significant thickening of the wall of the ascending colon. So the patient was hospitalized for further examination and treatment. And the Golgi and pathology showed the mucosal edema and the chronic inflammatory cell infiltration in the ascending colon. The 3rd case, 20 minutes after carotid CUS. So again, is a patient with the carotid CUS. This patient suddenly lost consciousness and was unable to answer the doctor's questions. Her face was pale, and she was unable to detect a pulse or blood pressure. Intravenous access was established immediately, and oxygen was administered. 5 minutes later, the patient was able to answer the physician's question. Systolic blood pressure was 80, and diastolic blood pressure could not be measured. 15 minutes later, the patient's face turned gray. Her blood pressure was 80/50. Her heart rate was 92, and her oxygen saturation was 97%. The patient was then transferred to the emergency department and given intravenous dexamethasone, sodium phosphate, glucose sodium chloride, potassium chloride, and calcium gluconate injection. About 4 hours later, the patient was discharged with complete resolution of symptoms. So this patient is very lucky. The 3rd case, 10 minutes after the cervical lymph node CUS, the patient developed severe abdominal pain, sweating, and fatigue. The patient was then immediately transferred to the emergency department. The blood pressure was 90/38, very low. And the patient was given intravenous dexamethasone, glucose sodium chloride, potassium chloride, and calcium gluconate. The blood pressure returned to normal. The day after CUS, the patient was discharged with complete resolution of symptoms. And the 4th case, this case is very interesting. The day after the breast CUS, the patient's left breast was swollen due to pain. The physical examination showed stable vital signs, slight yellow of the skin and scleral, large petechiae on the skin of the left breast and left chest wall, swelling of the left breast with significant pressure pain, no increase in skin temperature. The laboratory examination showed increased PT and APTT. The breast ultrasound showed the liquid echogenic area on the deep surface of the left pectoralis major muscle with well-defined border, ranging from 120 multiply 184 multiply 53 milliliter, which was considered a localized effusion. The patient underwent ultrasound-guided drainage of the left pectoral effusion. The brown viscous fluid was drained. 1 week after the operation, the patient still complained of significant pain in the left breast and drained about 80 milliliters of yellowish brown viscous fluid per day. The area of petechiae in the left chest and left chest wall continue to expand. Clinical consultation considered liver failure and infection as possible causes of coagulation dysfunction. Therefore, the patient received a combination of treatment, including blood transfusion, correction of coagulation abnormalities, capsule protection, and anti-infection. The patient's breast pain symptoms subsequently resolved, and the petechial area did not continue to expand, and the drainage decreased. So I have to think about the reason of the forecast, and I will introduce the definition of the AE, the adverse event. The adverse event is an adverse medical event that occurs in the subject during a clinical practice. So the AE do not necessarily have a parallel relationship with the drugs. So I think for this, the fourth patient situation is more complicated, and I think it may not necessarily have the relationship with the microbubble. The time to onset, 91% of the case have the AE within the 30 minutes of the contrast administration. So pay attention to the 30 minutes after the injection of the contrast agent. The time to regression, the majority of the patients recover on the day of the AE episode. And 2.5% of patients recover on the second day, and 0.6% recover on the third day. 4 patients, which is 2.6 patients with the life-threatening serious AE recovered after the hospitalization. So we need to note the pre-pression of the CEUS. First, we need to ask the patient's medical history to exclude the contraindications. We need to ask the patients if it has allergies, including the general allergies such as the allergies to the alcohol, seafood, eggs, milk, medication, etc. However, the allergy tests are not required before the use of contrast agents. Patients with allergies can prophylactically use the corticosteroid and antihistamines before the CEUS. We also need to ask the medical history, including the cardiorespiratory conditions, the medical history, whether it's pregnant or the breastfeeding, and the history of drug use. And we need to pay attention to some special population, such as the patients recently have the acute coronal syndrome, heart failure, severe arrhythmia, COPD, and the severe pulmonary hypertension. We need to have the informed consent. And the risk plans and the emergency drugs and supplies should be prepared. During CEUS, we need to have the close medical observation and the timely treatment should be carried out. For the high-risk patients, we should undergo the ECG and blood pressure monitoring during the examination. After CEUS, remember, we need to have the observation time no less than 30 minutes, because over 90% of the AE happened within 30 minutes after the injection, and we need to preserve the vene's access. So in conclusion, the Sonomil is a safe contrast agent with a low incidence of AE and is predominantly mild and moderate. For the clinical manifestation, the grading of AE, for the mild AE, the patients may have headache, nausea, vomiting, chills, rash, etc., and can live after rest. The treatment, we can provide oxygen, the intravenous exercise, and we need to exclude the hypoglycemic reaction. For the moderate AE, the patient may have the prolonged nausea, vomiting, diffuse urticaria, diffuse erythema, tightness of the throat, hoarseness, etc. And or we can give the patient oxygen, the sodium phosphate, dexamethasone, intravenous saline, oral glucose, and other treatments. For severe AE, the patient may have blood pressure drop. Immediately, we need to perform the anaphylaxis resuscitation immediately. So our team must master the emergency disposal process and skills. For the allergic, like the first line medication is adrenaline, 0.5 milligram intramuscular injection, or 0.1 milligram per milliliter, and 1 to 3 milliliter IV under the ECG monitoring. The second line medication is the glucocorticoid. For the physiologic symptom, like the severe vasovagal reaction, we use atropine, 0.5 to 1 milligram intravenous medication, and the total amount should be controlled within 2 milligrams. So always remember, the oxygen fluid and the adrenaline are the first line treatment, while the glucocorticoid and the antihistamines are the second line agents. And our team should regularly have the first aid training of the anaphylactic shock. It is very important for the safety clinical application of CEUS. And that's all for my presentation. Thank you very much.
Thanks a lot, really interesting presentation that confirmed what we already published several years ago, but it was needed to have this update from all of you. There are two questions for you. Again, Dr. Zhang, do we assess renal function before administration of a contrast?
No, we don't have to regularly assess the patient's renal function. It is very safe, but for some patients, it already has the AE, so we need to check the liver and the renal function.
Excellent. Yes, I totally agree with you. And also in our guidelines, we did the report in this way. Second question. Do conditions like atherosclerosis, lymphatic pathology, and deep venous thrombosis have any adverse effects on CEUS?
So I think the question, a doctor who asked the question may be his concerns the contrast agents cannot distribute it normally in this patient, right? I think first we inject this contrast agent from the our intravenous, and through the vein it goes to our blood circulation. So it can circulate to all our bodies. Maybe some parts of our bodies may have some stenosis, we have some thrombosis, but maybe it is not the the place that we concerns, and even it is the right position, and we need to take the examination. And I think there may be some phenomena or some imaging features it has, such as the for the atherosclerosis, if the artery have some stenosis, and the CUS, the contrast may make us see the stenosis more clearly. So I think there are no questions on these patients.
Yeah, I totally agree. In general, when we have a patient with a deep venous thrombosis or lymphatic drainage impairment, these are not contraindication for CUS. Sometimes we use CUS for evaluating thrombus to understand if it is neoplastic or non-neoplastic. But luckily, to now, we have not seen any kind of relationship with it, and as well as atherosclerosis. So far, I believe we don't have any other questions. If not, I really want to thank all of you, because it was a really interesting, comprehensive day in which you provided us the updated knowledge on what is already recognized, already established, but to have another confirmation from your point of view, I believe it is really important. And that's the reason, because in the future, as president of EFSUMB, as president-elect of EFSUMB, I will encourage to have more and more extended the panel of all the different countries of the experts in order to put together our knowledge, to try to harmonize our knowledge all over the world. I embrace all of you. I hope to see you soon. In October, I will be in China with you. Pinton One invited me in EFSUMB, so I will be there. And by now, again, CEST to everybody, and have a good night. Bye.
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 Thank you, Professor.
Thank you.
And